begin today's forum by talking about what is cardiovascular disease, CVD, and CVD risk estimation. Cardiovascular disease actually covers four main areas. The first two areas are what we are more familiar with. Coronary artery disease, which includes myocardial infarction, also known as heart attack, and ischemic heart disease. Cerebral vascular disease refers to stroke. Two other entities which the public may not be as familiar with are peripheral artery disease, which refers to the narrowing of blood arteries in the lower limbs, and also aortic aneurysm, which refers to enlarged arteries of the chest and abdomen. They are all part of the CVD spectrum. The underlying mechanism and cause for CVD is atherosclerosis, or simply put, plaque buildup. Plaque consists of fat, cholesterol, and calcium. And with time, accumulation, and buildup, they will lead to narrowing of arteries, and in the end, lead to end organ damage. For example, when coronary arteries gets narrow over time with plaque, they struggle to supply sufficient blood to the heart, causing chest pain, ischemic heart disease, and myocardial infarction. As a group, cardiovascular disease is the leading cause of death in Singapore, accounting for around 31% of mortality. In comparison, cancer accounts for 24%, and pneumonia, which is the infection of lungs, accounts for about 20% of mortality. Cardiovascular disease is a continuum that begins with modifiable lifestyle factors of smoking, physical inactivity, and high dietary fat. They progress into high-risk diseases such as hypertension, diabetes, dyslipidemia, and obesity. This in turn increases the risk of cardiovascular disease and mortality. While we can't do much about non-modifiable risk factors such as age and family history of CVD, we can certainly limit the damage made by these modifiable high-risk disease. The first step is to screen and detect these conditions. Based on current MOH guidelines, we can start screening for obesity through taking our BMI and hypertension through taking our blood pressure from the age of 18. For diabetes and hyperlipidemia, we can screen for them via taking our blood glucose level and blood lipid levels respectively, starting from age 40. With the blood pressure and lipid profile and other important parameters like age, gender, race, and smoking status, doctors can estimate a patient's 10-year CVD risk, i.e. the risk of having CVD, example heart attack, in the next 10 years, by using a heart risk calculator. Just to note, diabetic patients are generally considered at moderate or high-risk patients. Hence, diabetic status is not used in the calculation. Using the heart risk calculator, doctors can classify patients into three broad risk groups. Patients in the low borderline risk category have less than 10% risk of developing CVD in the next 10 years. Patients in the intermediate risk category have around 10 to 20% chance of developing CVD in the next 10 years. Patients in the high risk category have more than 20% chance of developing CVD in the next 10 years. Using an example to illustrate a patient in a low borderline risk category, an example would be a 52-year-old Chinese male, non-smoker, having a good lipid profile and also normal blood pressure. In contrast, if this patient was slightly older and having a poorer lipid profile and grade 1 hypertension, this would put him at an intermediate risk category. If the same patient were to be a smoker, having even higher cholesterol and poorer control of blood pressure, he'll be in a high-risk category. To add on, patients with established CVD, such as myocardial infarction, stroke, they will be in a very high-risk category, and there's no need for risk calculation for this group of patients. Similarly, for patients with diabetes or diabetes with end organ damage, they would automatically be in the moderate to high-risk category already. Risk assessment of CVD lays the foundation for primary prevention. It allows us to tailor our management for patients with hyperlipidemia in particular. This will be further elaborated in my talk on hyperlipidemia. This risk calculator is now freely available on your HealthBuddy app. With your blood test results, blood pressure profile, you can easily calculate your own 10-year CVD risk with a few simple clicks and data entry, just like what doctors do. This lab also allows you to know how your risk will be reduced if you can control your risk factors. Once again, to highlight, once you have conditions like diabetes, kidney disease, or CVD conditions, this app is not suitable for you. To sum up this segment, we went through the spectrum and cause of CVD, the risk factors of CVD and the importance of screening for the 3 highs and obesity, and the use of heart risk calculator for CVD risk assessment, as this will lay the foundation for primary prevention. I'll now move on to talk about combating the 3 highs: hypertension, hyperlipidemia, and diabetes. And first up will be hypertension. Hypertension is a condition in which the blood vessels have persistently raised blood pressure, or in short, BP. Blood pressure consists of systolic and diastolic BP. For systolic BP, it is the pressure exerted during heart contraction. For diastolic BP, it is the pressure exerted during heart relaxation. Globally, hypertension affects at least 20% of all adults, and it accounts up to 10 million preventable deaths due to cardiovascular disease. This is MOH's definition of hypertension, which is in line with European guidelines. The definition of hypertension is when systolic blood pressure is more than or equals to 140 millimeters mercury, and or diastolic blood pressure more than or equals to 90 millimeters mercury on 2 or more occasions. The definition of grade 1, 2, and 3 hypertension is shown here. Normal blood pressure is when systolic blood pressure is less than 130 and diastolic pressure less than 85. Anything in between normal blood pressure and grade 1 hypertension is known as high normal blood pressure. Mirroring global trends, hypertension is a common condition in Singapore, with around 1 in 3 adult Singaporeans having this condition. This condition affects more males than females, and the prevalence increases with age. There are broadly 2 types of hypertension, the more common type being primary hypertension, and it affects more than 90% of the patients. It occurs due to the complex interplay between genetic and environmental lifestyle risk factors, such as family history, age, excessive alcohol intake, high sodium diet, obesity, physical inactivity, and smoking. The less common type of hypertension is secondary hypertension and occurs up to 10% of the patient, and it can be caused by hormonal imbalances, kidney problems, medications, narrow kidney arteries, and obstructive sleep apnea. Taking an accurate blood pressure measurement is important for both diagnosis and monitoring for effects of treatment. Hence, these are the advice for taking blood pressure. Before taking our reading, we should have no food or drink for around 30 minutes. We should also empty our bladder. And during the reading, we should not be talking. Our arms should be resting at chest height, the cuff against the bare skin, our backs supported, and we are seated with our feet flat on the floor. Hypertension is usually picked up during screening when patients do not have symptoms. Some other times, in the setting of poorly controlled hypertension, patient can have chest pain and breathlessness, persistent headache, blurring of vision, or even nosebleeds. And this is a situation where hypertension can be diagnosed. When doctors see a patient with hypertension, the evaluation begins with a detailed history and examination. Urine tests will be done to check for abnormal levels of urine protein, blood tests to check for kidney function, electrolytes, glucose, and lipid level. BMI will also be measured. ECG will be done to check for cardiac complications of hypertension. More tests would be needed if any of the initial screening tests are abnormal. Lastly, the consult will end with an appropriate education and counseling of patients with regards to initial treatment of hypertension. One of the factors in determining whether medication is needed is whether any of the major organs are affected by hypertension. Hence, we look for hypertension-mediated organ damage, or in short, HMOD, which includes the cardiovascular spectrum of diseases such as stroke, heart failure, heart attack, peripheral artery disease, and eye and kidney complications. Treatment strategy depends on the severity of hypertension and presence of HMOD. Lifestyle management is essential for all stages of hypertension. For patients with high normal blood pressure, on top of lifestyle modification, we should consider medication in very high-risk patients or in patients with CVD. In patients with grade 1 hypertension, immediate drug treatment should be started for high-risk patients or those with cardiovascular disease, HMOD. For other patients, drug treatment should be considered after a 3 to 6 months duration of lifestyle intervention if blood pressure is not controlled. For grade 2 and grade 3 hypertension, there should be immediate drug treatment for all patients, and we should aim for blood pressure control within 3 months. Blood pressure are based on age and the presence of HMOD. Generally speaking, for most situations, we usually target for blood pressure of around 130 and 80 for patients in the age group of 18 to 65. For patients more than 65 years old, we aim for a BP target of 140/80. As lifestyle modification is important, it cuts across all management of the 3 highs. Based on existing guidelines, we should aim for 150 to 300 minutes a week of moderate intensity physical activity. Examples include brisk walking, slow cycling, dancing, or 75 to 150 minutes a week of vigorous intensity physical activity. Examples include running, fast cycling, or competitive sports. If the above 2 cannot be achieved, then we should minimally be targeting light intensity physical activity throughout the day to reduce sedentary time. Last but not least, we should aim for resistant exercises, example dumbbell, resistant band exercises, for 2 or more times a week. Having a healthy diet is important as well. A heart-healthy diet is beneficial for patients with the 3 highs. A healthy diet should be heavy on beneficial foods. For example, you should have 2 servings per day of vegetables, fresh fruits, whole grains, 1 serving per day of low glycemic index refined cereal, nuts and seeds, 4 servings per week of legumes and fish. For neutral fruits such as white meat, eggs, cheese, and milk, there should be no more than 3 servings per week. For unhealthy foods, we should limit them to no more than 2 servings per week. For example, high glycemic index refined starchy foods, red meat, butter, and occasionally only for processed meat. Other dietary advice include we should have less than 5 grams of salt per day, cut down on soft drinks. We should drink at least 2 liters of water a day as well. In terms of alcohol advice, we should drink no more than 2 glasses of wine or 1 can of beer a day, and we should cut down on fried and battered food as they contain a lot of trans fats. So in summary, we touched on the definition and types of hypertension. In terms of management of hypertension, we went through the indications of medications, blood pressure targets. In terms of lifestyle modifications, we went through physical activity and dietary control. Smoking cessation and obesity are important aspects as well, and these will be discussed in detail later. Now, moving on to hyperlipidemia, which is the second high I'd like to talk about. It is a condition where our body has too much cholesterol or lipids. Cholesterol is a fat-like substance that is either produced by the body or derived from food. Cholesterol is carried in the bloodstream by special proteins called lipoproteins. Low-density lipoprotein, in short LDL, is known as the bad cholesterol. It increases the risk of plaque buildup in arteries and, in turn, increase the risk of heart attack or other forms of CVD. High-density lipoprotein, in short HDL, is a good form of cholesterol. It removes cholesterol from the cells before they are deposited in the plaques of arteries. Triglyceride, in short TG, is the most common type of cholesterol. It stores excess energy from our diet. High levels of TG, together with high LDL, can increase the risk of CVD. Hyperlipidemia can be defined in several ways. Firstly, we diagnose hyperlipidemia when LDL is more than or equals to 4.1 millimoles. Secondly, we look at total cholesterol, and there is hyperlipidemia when the total cholesterol is more than or equals to 6.2 millimoles per liter. Thirdly, when TG is more than 2.3 millimoles per liter, we can also diagnose hyperlipidemia. Generally, if hyperlipidemia is purely due to raised HDL, which is the protective form of cholesterol, no further action is required. Hyperlipidemia is a common condition in Singapore and affects about 1 in 3 of Singaporean adults. It affects more males than females, and the prevalence of hyperlipidemia increases with age. The risk factors for hyperlipidemia includes modifiable risk factors such as physical inactivity, obesity, unhealthy diet, excessive alcohol intake, pre-existing medical conditions such as diabetes, hypothyroidism, and kidney disease. Non-modifiable risk factors include family history of hyperlipidemia and increasing age. For lifestyle management, we adopt a 4-pronged approach, focusing on healthy diet that's heavy on vegetables, fruits, nuts, fish, and whole grain. For physical activity, we should be aiming for at least 150 minutes of moderate intensity physical activity or 75 minutes of vigorous intensity physical activity. For weight management, we should be targeting a normal BMI range of 18.5 to 22.9. And for patients who are smoking, they should stop smoking altogether. In terms of medications, they should be started when LDL is not on target. And the target LDL depends on the patient's 10-year CVD risk. Applying what we have already learned, for someone in the low borderline risk category, they have a less than 10% chance of developing CVD. Their target LDL is 3.4 millimoles per liters. And medication should be considered if LDL is more than 4.1 persistently despite lifestyle modifications. For someone in the intermediate risk category, we should be aiming for an LDL of less than 2.6 millimoles per liter. And if they're hypertensive, like for example, this patient highlighted here, the blood pressure target should be around 130/80. For patients in the high risk category, the LDL target should be stricter and should be less than 1.8 millimoles per liter. And the blood pressure target, if they're hypertensive, should be 130/80. Patients in the very high risk category are those that have established CVD, conditions such as myocardial infarction. They would usually be already on a high dose of statins or medications to bring down LDL. The LDL target for this group of patients should be less than 1.4, and the blood pressure target, if they're hypertensive, should be around 130/80. There are several types of oral medications we can use to lower LDL. Statins is the most common oral medication used for this purpose. They can reduce LDL by up to 50%, and they work by slowing the liver's production of LDL and increasing the liver's ability to remove LDL. It also has anti-inflammatory properties that stabilizes unstable plaque in heart arteries. Common side effects to look out for include muscle aches, which can occur up to 5% of patients. This is usually not a serious side effect and can usually be tolerated. If it can't be tolerated, we can deal with this issue by either lowering the dose of statins or switching the class of statins. Liver inflammation is another condition we should look out for. It occurs up to 1% of patients. We deal with this issue by close monitoring of liver enzymes and stopping of statins when liver enzymes rise significantly. Atorvastatin is one type of statin, and which also goes by the trade name of Lipitor. Ezetimibe or Ezetrol, as its trade name, reduces LDL absorption for the gut. The combination of statins and ezetimibe can bring about a 65% reduction of LDL. A new class of injectables have emerged in recent years, which provide an alternative for patients who are unable to achieve LDL targets or are statin intolerant. These are usually reserved for patients at high risk of CVD or with established CVD. They can lower LDL by 85% in combination with both statins and ezetimibe. The first group of such injectables I'd like to highlight is PCSK9 inhibitors. They are monoclonal antibodies which block the production of PCSK9, a protein that degrades LDL receptors. This in turn increases LDL absorption from the bloodstream into liver cells. These are subcutaneously injected medications and should be injected once every 2 weeks. Eviloculumab is an example of PCSK9 inhibitor, and it goes by the trade name of Repatha. Another example is aleucolimab, which goes by the trade name of Praluent. Currently, the main barriers to uptake is the cost of these medications. They can cost up to more than $7,000 a year. The good news is that Repatha will be eligible for a significant financial subsidy from November this year onwards. Hence, we do expect a greater uptake in this medication. Inclisiran, or known by the trade name of Leqvio, is another class of injectables. It is a small interfering RNA that reduces upstream PCSK9 production, and this in turn increases LDL absorption. It is a subcutaneously injected medication and should be injected every 6 months. It is a costly medication currently and can cost up to $3,000 a year, and unfortunately, it is still not eligible for financial subsidy. To sum up this part, we've went through the diagnosis of hyperlipidemia, and the focus here is really on LDL reduction. Target LDL level is based on CVD risk. Studies have shown that there's a linear relationship between LDL and cardiovascular events, meaning to say, the lower the LDL, the better it is for cardiovascular disease protection. Hence, especially for patients with established CVD, the lower the LDL, the better. Now, moving on to diabetes, or in short, DM, this condition is characterized by having a high blood sugar level. There are 3 forms of DM. Type 2 DM is the most common form. It affects about 90% of patients. In this condition, the body is still producing insulin, but in insufficient amounts. Type 1 DM affects 10% of the patients. In this condition, insulin production is absent. Prediabetes is a condition where individuals have higher blood sugar levels, but not yet in the diabetic range. This is subdivided into impaired glucose tolerance and impaired fasting glucose. Diabetes affects about 1 in 12 of Singapore's adult population, and there is a higher proportion of males being affected with DM versus females, and the prevalence of this condition increases with age. The risk factors for DM include modifiable risk factors such as obesity, physical inactivity, medical conditions such as hypertension and hyperlipidemia, and excessive alcohol consumption. Non-modifiable risk factors include age, history of gestational diabetes, and family history of DM. Diabetes can be a silent condition, or patients can also have the following symptoms: feeling thirsty despite drinking lots of water, frequency in passing urine, feeling hungry all the time, losing weight despite having a good appetite, having blurred vision, or having poor healing of cuts and wounds. Based on Singapore guidelines, DM can be diagnosed when either of the 3 criteria is met. First, fasting blood glucose of more than or equals to 7.0 millimoles per liter, or 2-hour blood glucose after oral glucose tolerance tests of more than or equals to 11.1, or having a HbA1c of more than or equals to 7.0%. HbA1c refers to the percentage of hemoglobin saturated with glucose. For patients who are pre-diabetic, in particular, impaired fasting glucose, their fasting glucose will be in the range of 6.1 to 6.9. For patients with impaired glucose tolerance, their glucose level 2 hours post OGTT will be between 7.8 to 11.0. For lifestyle modification for diabetes, in terms of diet, physical activity, and smoking cessation, the approach is identical to how we deal with hypertension and hyperlipidemia. With regards to weight management, when diabetic patients are overweight, diabetic medications with weight loss benefits should be considered. In addition, when BMI is more than 35, despite lifestyle and medications, bariatric surgery should be considered as well. Dr. Sarah Tan from SGH Endocrinology will be talking more about this topic later. In patients with established cardiovascular disease, we should be giving them medication with cardiovascular benefits. One such medication is metformin, which belongs to the biguanide group of medication. It goes by the training of glucophage, and it works by decreasing liver production of glucose and increasing the body's sensitivity to insulin. It is a well-established medication and is still the mainstay of treatment for DM due to its efficacy, safety, and duration of evidence. Its cardiovascular benefits has been known since the 1970s, and metformin improves blood vessel function, lipid control, and has weight loss benefits. Newer glucose-lowering medications target numerous novel pathways to reduce cardiovascular and renal events in diabetic patients. I want to highlight two groups of such medications which have very good and robust data on cardiovascular benefits. First is the group sodium glucose cotransporter 2 inhibitors, or in short, SGLT2 inhibitors. It exerts its cardiovascular benefits through blood pressure control, relaxation of arteries, and has renal protective effect and weight loss benefits. An example of SGLT2 inhibitor is dapagliflozin, which also goes by the trade name of Forxiga. The second group of medication I'd like to highlight is glucagon-like peptide 1 receptor agonist, or in short, GLP-1 receptor agonist. It works by stimulating glucose-dependent insulin release from the pancreas and delays gastric emptying. It exerts its cardiovascular benefits through blood pressure control, improved blood vessel function, and reducing inflammation. In addition, it has weight loss benefits too. An example of GLP-1 receptor agonist is semaglutide, which is a weekly injected medication, and this also goes by the trade name of Ozempic. After patients are diagnosed with DM and started on medications, we use HbA1c to monitor their sugar or glycemic control. As mentioned earlier, HbA1c refers to the percentage of hemoglobin that's saturated with glucose. It monitors the patient's average blood sugar level over the past 3 months, and is used for both diagnosis and assessment of DM control. For elderly patients with relatively shorter life expectancy and more comorbidities, we usually have a more lenient target HbA1c for such patients, usually less than 8.5. For younger patients with relatively longer life expectancy, we usually target a stricter HbA1c target of less than 7.0%. With regards to cholesterol lipid targets, as most people with diabetes is considered to have at least a moderate CVD risk, it is reasonable to target an LDL of less than 2.6 minimally and to be on at least a moderate dose of statins. As mentioned in my earlier talk, there's a linear relationship between LDL and cardiovascular events. Hence, for patients in a high risk group, it is reasonable to have lower LDL levels, i.e., the lower, the better. So in summary, I went through the diagnosis of diabetes. Also for lifestyle management, I highlighted the use of medications with weight loss benefits and the consideration for bariatric surgery for obese patients. For diabetic patients with cardiovascular disease, we should start on medications that has cardiovascular benefits. Lastly, patients with diabetes should have good glycemic and also lipid control. With the advancements of medical science, we now have non-traditional cardiovascular risk markers that can help us refine the management of patients in the intermediate risk category. Firstly, we can have the CT scan of the heart to detect calcium deposits in heart arteries. This test is called coronary artery calcium score, in short CACS. We can also do blood tests looking at levels of inflammation, such as hsCRP, or blood tests looking at elevation of special types of cholesterol, such as apolipoprotein BA or LP(a). Lastly, we can also look at ankle brachial index. We can obtain this index by doing a blood pressure measurement at the level of the ankle, and we divide this by the blood pressure at the level of the at the arm. Abnormal levels would indicate peripheral artery disease. Among the tests listed here, NHCS is the most widely adopted test by cardiologists. This is because NHCS is the most reliable predictor of long-term CVD-related mortality. It is highly specific for coronary atherosclerosis, and from a practical point of view, helps to guide the initiation of statins and aspirin. The calcium score is computed based on volume and density of calcium deposits. The higher the score, the higher the risk of CVD. The picture on the extreme left shows absence of coronary calcification. The middle picture shows moderate calcification. We can see from the circle area, the bright spots indicate coronary calcification, atherosclerosis. The picture on the extreme right shows severe calcification. The circle area shows bright spots which are more intense and extensive. So how do we interpret calcium score? A calcium score of 0 indicates very low risk of CVD, and it is reasonable to withhold statins. Calcium score of 1 to 99 indicates mildly increased risk of CVD, and in this situation, we can consider statins. Calcium score beyond score of 100 indicates at least moderately increased risk, and guidelines support the initiation of statins and consideration for aspirin. The decision to start either of a medication is a shared one between both doctors and patients, and the decision should be made after a discussion regarding risk and benefits of the medication. Lastly, to sum everything up, this is the ABCDE of primary prevention, adapted from the 2019 American guidelines. Firstly, A stands for assessing risk, and we can now do so via a heart risk calculator on our HealthBuddy app. A also stands for aspirin, and aspirin should be reserved for patients in the high-risk category. B stands for blood pressure management, and hypertensive patients should have a target blood pressure of around 130/80. C stands for cholesterol lipid management, and this involves risk assessment, lifestyle management, medication, and use of CACS in selected patients. C also stands for cigarettes, and smokers should completely quit smoking using pharmacotherapy and behavioral interventions. D stands for diet and weight management, and the emphasis is now on healthy food, such as vegetables, fruits, nuts, legumes, fish, and whole grains. D also stands for diabetes, and we control this condition via diet, exercise. Medications with cardiovascular benefits include metformin, SGLT2 inhibitors, or GLP-1 receptor agonists. Last but not least, we should exercise and aim for more than 150 minutes of moderate intensity physical activity, or more than 75 minutes a week of high intensity physical activity. If we can do the ABCDE well, then we can have a high chance of keeping heart attacks at bay. With this, I conclude my presentation. Thank you very much for your attention.